Good afternoon, everyone. Just confirming that you can see our screen. We're in the presentation mode.
Correct.
Thank you. All right. This is the oral presentation that Dr. Sawari and I presented at ID Week 2025. Clinical trials have traditionally been used to answer scientific questions. We'll be presenting implementing the Comparing Oral versus Parenteral Antimicrobial Therapy, or COPAT, clinical trial to influence institutional practice transformation in addition to answering a scientific question. I'm Joy Juskowich.
And my name's Arif, and we will start off straight away using the teaching tool that was developed, the COPAT Trial Jeopardy tool. This included cases from the patients that participated in the trial and had good follow-up results. Can I request that you please scan this QR code? It will take you to a link where you should be able to add a little bit of a demographic information, just 4 or 5 questions. Please go ahead and submit the answers to those questions, and it will then take you to a page where you will be answering one specific question on all the cases that we present. So just making sure you've had a chance to log on and submit the demographic questions, and we will go straight into the COPAT Trial Jeopardy. So the COPAT Trial Jeopardy titles were inspired by the ERAS tour that was going on at that time. And we will have 2 cases each on endocarditis, titled Bad Blood, bone and joint infection, or Castle's crumbling, and then miscellaneous infections, or blank space. And for each one of these questions, there is one single question that we would like you to answer. Given the clinical scenario presented with the patient on IV antibiotics, what we are measuring or assessing is your comfort level, your current comfort level with transitioning this patient from IV to oral antibiotics. All right, we'll start off with our first endocarditis patient. A 57-year-old male was admitted in August at Ruby for shortness of breath and extreme fatigue that had been going on for a few months. He does have an underlying history of aortic stenosis. His blood cultures confirmed a streptococcal infective endocarditis of a native bicuspid valve. The penicillin MIC to the strep was in the intermediate range at 0.25. The patient underwent an aortic valve replacement very early, within a few days of his hospitalization. His operative gram stain was positive, but the cultures were negative. Pathology confirmed the diagnosis of infective endocarditis. At this point in time, the patient is receiving IV ceftriaxone. What is your current comfort level at day 3 post-op, transitioning this patient from IV antibiotics to oral antibiotics? If you could record your answer for the first endocarditis case. So this patient was randomized in the COPAT trial to the experimental or early oral transition and was treated with a 4-week course of levofloxacin 750 milligram daily. The peak serum concentration of levofloxacin at that dose is about 12, which is well above the 10-fold higher than MIC that we usually look for. At his 12-week visit at the end of the trial, the patient was noted to have completed his antibiotics as planned and was doing very well. So case 1 is essentially a 57-year-old male, underlying aortic stenosis, admitted with streptococcal native bicuspid aortic valve endocarditis, who undergoes an aortic valve replacement, who has negative intraoperative cultures, and is then treated with 4 weeks of oral levofloxacin, noted to be doing well, 2 months of his antibiotics, And for all these cases, we'll give you a maximum CRP and their last CRP at the time they were finishing the trial. All right, case number 2, still with the endocarditis theme. Younger patient, 33-year-old male with a history of an ascending aortic aneurysm, was hospitalized in the month of October for a subacute illness with fever, aches, and headaches. His blood cultures grew a viridans group strep with a low penicillin MIC of less than 0.1, and he cleared his blood cultures quite rapidly. His transesophageal echo confirmed the bicuspid aortic valve with severe regurgitation, mildly reduced EF, and a severely dilated aortic root and ascending aorta. On the 23rd of October, he underwent a valve repair as well as a replacement of the ascending aortic root. Unlike the first patient, his intraoperative cultures were positive for the viridans group strep. 3 days post-op, he's on IV ceftriaxone. What is your current comfort level transitioning this patient from IV to oral antibiotics, knowing that his intraoperative cultures are positive? This patient was also randomized to the experimental arm of the COPAT trial and transitioned to amoxicillin, 1 gram 3 times a day. My peak serum level with amoxicillin is 10 to 15, which again is way over the 10-fold threshold that we are usually looking for. He was treated with a 6-week course. So case number 2 is a 33-year-old male with streptococcal native bicuspid aortic valve endocarditis, who has undergone a valve repair and root replacement, who's completed 6 weeks of amoxicillin and is doing very well. Maximum CRP 83, last CRP 4.0. All right, let's transition to bone and joint infection. So the first case here is a young female who has a chronic skin illness, lichen simplex chronicum, because of which she has some ulcerative skin changes, mostly on her elbow region. She was admitted with a left sacroiliac septic arthritis and an iliopsoas pyomyositis. So this is what your sacroiliac joint should look like. Hers look like this. On the left side, you can see a very destroyed sacroiliac joint with a lot of inflammatory process around it. She underwent a CT-guided biopsy, and this was culture positive for MRSA. Her blood cultures were negative during this admission. What is your current comfort level transitioning this patient from IV to oral antibiotics? She was randomized to the experimental or early oral arm and treated with a course of linezolid. We planned for a 4 to 6 week course based on CRP normalization. Due to a decrease in her platelet counts, her linezolid was switched to doxycycline for the last 2 weeks. So essentially a young female with MRSA, left sacroiliac septic arthritis, and iliopsoas pyomyositis, who was treated with oral linezolid, maximum CRP 66, and her recent one was close to normal. All right, second case for musculoskeletal is a 71-year-old male who follows with our MSK ID clinic for left prosthetic hip infection. His original hip arthroplasty was at a different institution in 2022. He had established care with our clinic in 23, and an IR aspiration in October 23 had grown Enterobacter cloacae complex. The patient underwent a resection arthroplasty on the 16th of the chronically infected left total hip replacement, followed by insertion of an articulating antibiotic spacer. As expected, his operative cultures grew the same Enterobacter cloacae complex. What is your current comfort transitioning this patient from IV to oral antibiotics? This patient randomized to the experimental arm and was treated with a course of levofloxacin with an end date of November 27. So essentially, we're talking about a 71-year-old with late prosthetic hip Enterobacter infection who undergoes a resection arthroplasty, placement of an articulating antibiotic spacer, who is treated with a course of Levaquin and noted to be doing well at his 3-month follow-up visit. Maximum CRP 116, most recent CRP 15. All right, let's do a couple of miscellaneous infection cases. First case is a 74-year-old female who is hospitalized as a transfer from Camden Clark with acute cholecystitis with a hepatic abscess, as can be seen on this imaging study. She underwent a CT-guided abscess drainage and a cholecystostomy tube placement, and the cultures from both grew Citrobacter. For this patient, what is your comfort level transitioning from IV antibiotics to oral antibiotics? This patient was randomized to the oral arm of the COPAD trial, was treated with a course of levofloxacin and metronidazole. She completed 6 weeks following her drainage procedure with a repeat CT showing complete resolution of the abscess. So essentially, an elderly female with acute cholecystitis, pyogenic hepatic abscess with Citrobacter, now showing imaging study with a resolution of the abscess after a 6-week course of Levaquin and metronidazole. She did subsequently undergo an elective cholecystectomy. Maximum CRP 117, last CRP 1.2. And our last case on the Jeopardy teaching tool is a 63-year-old male with underlying poorly controlled diabetes admitted with an MSSA left iliopsoas pyomyositis and perinephric abscess with bacteremia. And if you look at his imaging study, you can see the inflammatory process in the inferior pole of the kidney extending into the iliopsoas region. His urine cultures grew the MSSA. His blood cultures grew MSSA between the 16th and the 21st and cleared on the 23rd. She underwent a CT-guided left perinephric abscess drainage with a catheter placement for source control, and the sterile site culture confirmed MSSA. The drain was subsequently removed later. Patient is on IV antibiotics for this MSSA, bacteremia, and pyogenic process. What is your comfort level transitioning this patient from IV to oral antibiotics? This is another patient randomized to the oral arm who received IV cefazolin until the clearance of bacteremia was confirmed at 48 hours, and then transitioned to cefadroxil at the higher 1 gram BID dose and completed a 4-week course. So a 63-year-old female with MSSA left iliopsoas pyomyositis, perinephric abscess with bacteremia, who undergoes drainage procedures, who has completed a 4-week course of oral antibiotics with CRP normalization and clinically doing well at the 12-week follow-up visit. So these were the 6 teaching cases. And we do have a couple of final Jeopardy questions we would like you to answer, please. So the first question is, after reviewing these 6 cases, do you feel more comfortable with earlier transition from IV to oral antibiotics? Yes or no? The second question is a little more personal. What would you do for yourself if you needed prolonged antibiotics and had good oral options? Would you still prefer to get a PICC line and start with IVs for a duration of time? And again, yes or no answer. Appreciate you all answering these questions, and we'll be back with the answers to some of these questions.
As Dr. Sawari said, these are actual teaching cases from our comparing oral versus parenteral antimicrobial therapy or COPAT trial. The COPAT trial was conducted to extend even earlier oral antibiotic transition and from infective endocarditis and bone and joint infection to almost all infectious diseases. Early oral antibiotic transition for infective endocarditis is amply supported by the POET trial, which was published in 2019. And similarly, the OVIVA trial, published at the same time, anchored this concept for bone and joint infections. In POET and OVIVA trials, patients transitioned to oral antibiotics at 7 to 10 days. And since then, there have been over 20 published studies for reviews. COPAT trial was an open-label, pragmatic, randomized control trial conducted across 5 IV faculty staffed hospitals in one health system, WVU Medicine. Target enrollment was 135 patients, otherwise being discharged with at least 2 weeks of IV antibiotics, who were randomized 2-to-1 to receive early oral or experimental versus continued IV or control antibiotics. The trial had 2 primary hypotheses and outcomes. The early oral group safety superiority, on which our sample size was calculated, and efficacy equivalence, as had been demonstrated in multiple other trials. Patients followed in ID clinic, and at the 12-week mark, assessment of clinical cure was independently conducted by 2 ID faculty who were blinded to study arm. The trial was stopped early at the second planned interim analysis at 2/3 enrollment due to a significant safety benefit in the early oral group. And this table shows demographics and infection type characteristics. So both groups were similar in age and gender distribution. While not found to be significant, the early oral group had a 2-day shorter length of stay. And there was a predominance of endovascular and bone and joint infections. Staphylococcus aureus was the most commonly isolated organism, and it accounted for 25 of the 43 patients with bacteremia. All patients except for 1 had complicated Staphylococcus aureus bacteremia. A surgical or drainage procedure was by chance performed more often in the early oral group. This figure shows proportion of total antibiotics administered intravenously or orally. Both groups were similar in average total antibiotic duration of approximately 6 weeks. In the early oral group, patients received almost 90% of the course with oral antibiotics, with oral antibiotic transition occurring in a median 4 days, which is earlier than the 7 to 10 days in POET and OVIVA trials. While the continued IV group received predominantly IV antibiotics, over 1/3 of the course was completed with oral antibiotics, which is consistent with our standard of care with the COPAT program. The patient satisfaction survey was administered at the 6-week mark, and it showed a strong preference for oral antibiotics. And the 5 most common oral antibiotics were cefadroxil, linezolid, levofloxacin, amoxicillin clavulanate, and metronidazole. Like with other studies, therapeutic efficacy was found to be equivalent. And this table shows safety and adverse events. There were a total of 46 events in 33 patients. Total event rate, measured in events per enrolled patient week, was 3.2% in the early oral group and 6.5% in the continued IV group. This difference was driven by line-related adverse events and statistically significant, as well as supported our hypothesis. The cumulative hazard for first study-related adverse event was lower in the early oral group and shows curves separating by day 10. So our conclusions included that early IV to oral transition significantly improves antibiotic treatment safety without compromising effectiveness across most serious infectious diseases, and the patients report a strong preference for oral antibiotics.
Another very overt reason for doing this trial was to accelerate practice transformation across our system, across our institution, towards earlier oral transition of antibiotics. So the trial literally had this primary design where we were trying to influence practice transformation. We have very robust OPAT and COPAT programs. Our OPAT program is older and well established. And at the time of the institution of the trial, our COPAT program was a nascent program and received far fewer consults than the OPAT program did. We felt that the difference was based on the variability in comfort levels among providers for the early transition. So this is not apparently a data science problem. It appears that this is mostly an implementation science problem. The variability in comfort levels was confirmed by the results of the COPAT trial Jeopardy teaching tool. So just like we administered the same 6 questions to this audience, we administered the Jeopardy teaching tool to a Department of Medicine Grand Rounds audience to about 49 participants with exactly the same cases. And you can see a significant variability in people's comfort levels with transitioning from IV to oral. For example, only 35% of the participants at this Department of Medicine Grand Rounds were comfortable or very comfortable for the 2 endovascular cases that we discussed here. And that might have been a similar results to what we could have polled with yourselves as well. You can see that the comfort level improves after using the teaching tool to 90%. And it is also interesting that the comfort levels with bone and joint and miscellaneous infections seems to be higher. The measure of practice transformation was the ratio of COPAT to OPAT consults monthly as measured across the implementation of the trial. We feel that implementing the COPAT trial helped improve practice transformation in the sense that for every 10 patients enrolled in the COPAT trial, the ratio increased by 0.06, and this was a significant increase. Practice transformation is also evident in the fact that 2/3 of the trial enrollment occurred within the first 6 months of the trial, with only 1 patient enrolled in the last 3 months of the trial. The dotted lines show you the time periods at which the COPAT trial or a version of that was implemented at different forums, including the Department of Medicine Grand Round Jeopardy, which was administered on May 17, 2024. Clearly, based on these results, we feel that implementation of the trial did help us accelerate practice transformation to earlier oral antibiotic transition across our system. We feel that the more important question to answer is why is there such a difference in practice comfort levels? And some of this has to do with the way we are taught. A lot of us still believe very firmly that for serious infections, IV antibiotics are safer. Now, our pharmacy colleagues are teaching us that oral antibiotics have great absorption, and the literature is amply supporting us that serious infections can be treated with oral antibiotics. And in fact, as suggested by the COPAT trial, IV antibiotics, particularly by needing line access, may be more dangerous. Now, if you compare the last 2 sentences on this slide, that is where we create cognitive dissonance. And we think that's a big driver of why we are so uncomfortable with this notion of earlier transition from IV to oral antibiotics. So how do we overcome cognitive dissonance? it will need a paradigm shift in terms of how we answer the question. The answer to the question, are IV antibiotics more effective than oral, is not that no, oral antibiotics are just as effective. It's really that IV antibiotics are more dangerous than oral antibiotics. Implementing the COPAT trial across our health system taught us that systems that are going to be able to implement a program with early transition from IV to oral antibiotics will produce a win for patients who overwhelmingly prefer oral antibiotics and will have fewer side effects, a win for the providers who will see a potential 1 to 2 day decreased length of stay, as well as a win for the system itself. Any program that is able to deliver increased healthcare safety at a decreased cost produces improved value.
In summary, early IV to oral transition by day 4 significantly improves antibiotic treatment safety without compromising effectiveness across most serious infectious diseases. Patients report a strong preference for oral antibiotics, 91%. And implementation of the COPAT clinical trial accelerated practice transformation to earlier IV to oral antibiotic transition in WVU medicine. We'd like to acknowledge the West Virginia University Department of Medicine, our Clinical and Translational Science Institute, our co-investigators, and above all, our patients. Thank you. We're happy to take any questions.